Welcome everybody to week one of the Section 100 antiretroviral prescribers training course. My name's Dr. Mark O'Reilly. I'm an HIV specialist, GP and sexual health physician at Prahran Market Clinic down in Melbourne. So I'll be presenting over the next 90 minutes or so the first of the four modules, which is called Initiation of Antiretroviral Therapy. Here are my disclosures. So by the end of this talk, we would hope that you're familiar with different HIV drug classes and the HIV viral life cycle. You will have watched the video already in the online module that you've already done. We'll take a look at some first-line drugs or first-line treatment regimens and their specific toxicities. We'll also have a look at alternative drugs and toxicities, as well as drugs which we previously used but are no longer recommended, but potentially still listed on the PBS. We'll also have a look at some class-specific drug interactions, and we'll talk briefly about resistance. So we've divided this first week, initiation of antiretroviral therapy. Initiating the antiretroviral therapy. We've divided into four separate sections. We'll first take a look at preparing for antiretroviral therapy. Then we'll take a look at the common first-line regimens, pharmacology and drug interactions, and finally resistance. Okay, so preparing for antiretroviral therapy. Really, we break it down into four steps. So we need to provide education, ensure that our patients are ready to commence antiretroviral therapy once they've been diagnosed with HIV. We want to take a good look at all of ensure that we've performed and then reviewed all of our baseline investigations. We want to then look at specific circumstances or special circumstances, clinical scenarios, which might impact on the specific HIV combinations that we choose to initiate. And finally, we'll actually choose the antiretroviral regimen. So in terms of assessing patient readiness or education, I think it's good to put the HIV story in Australia into context. So HIV, as you know, was first discovered in 1983 and further characterised in 1984. In the years after the discovery of HIV, we didn't have any medications to treat HIV. And unfortunately, a lot of people died at this time. And so what we were doing in the early years of the HIV epidemic was seeing people regularly, performing CD4 counts and other blood tests to monitor the immune system and their general well-being. But we couldn't offer them any HIV medications, any antiretroviral therapies, simply because we didn't have any. And then in the late 1980s, early 1990s, as you may know, AZT, the first antiretroviral agent, came along. So in that period, prior to actually having antiretroviral therapy to offer, what we were able to do was to provide supportive care for individuals living with HIV, but also to monitor the natural history of untreated HIV, something fortunately we don't get to do nowadays. And so what that allowed us to do ultimately was to be able to understand at what CD4 count thresholds people may run into trouble with AIDS-defining illnesses and what those common illnesses were, but also to work out when we might be able to offer prophylactic antibiotics, whether that's for PJP pneumonia or MAC, when CD4 counts fell below 200. And so that period of observation was very, very important. And although we often weren't treating people, we were still gaining a lot of really important information, which influences how we care for people living with HIV today. So in the early days, we didn't have any drugs, and then AZT came along, and then other medications shortly thereafter. But those drugs came through fairly quickly, and what we discovered is that while they prolonged life and potentially saved lives, they also were associated with some very significant side effects and toxicities. AZT, for example, was associated with anemia and headaches, and unfortunately, when it was first used, it was used as higher doses than used now, and unfortunately was associated with some fatalities also. But in the early days, when we had nothing else to treat, we took this hard hit early approach. So the first drugs come along, we're losing people to HIV and AIDS, and so the strategy is to treat as soon as we're able. But over time, we realised that the early HIV drugs were associated with significant toxicities. And given we'd had this period where we were monitoring people who were not yet on treatment, we had a reasonable understanding of when they would run into trouble with opportunistic infections and AIDS-defining illnesses. So after a while, we decided to back off from that hit hard, hit early approach and to actually initiate antiretroviral therapy when somebody's CD4 count fell below 200. And so there was a period in HIV management in Australia where people were not offered treatment at diagnosis, but if they developed either symptomatic HIV infection or their CD4 count fell below 200 cells per microliter, they'd then be offered treatment with antiretroviral medications. Over time, though, the antiretroviral drug combinations improved in terms of their toxicities, in terms of their pill burden. And we also began to realise that waiting until the CD4 count of 200 occurred was perhaps leaving things a little bit late for some individuals. And so the CD4 count threshold for initiation of ART in Australia was increased from 200 up to 350. But again, over time, our medications improved. By 2010, we got our first single pill regimen available in Australia, which was called ATRIPLA. Our medications continued to improve. And again, we realised that perhaps waiting until an individual's CD4 count fell below 350 was also a bit late. And so in 2010, the recommendation was that individuals who fell below 500 or had symptomatic HIV infection should initiate treatment. At this time, though, of improving treatment, we also started to understand the concept of treatment as prevention, that if an individual living with HIV was on treatment with an undetectable viral load, that they may not be able to transmit HIV to their sexual partners. And we have a lot more evidence about that now. But by 2014, we had a good understanding that treatment of the science behind treatment as prevention, but also the benefits to the individual living with HIV if they start at higher CD4 count thresholds. And so by the 1st of April 2014, the decision was made to remove the CD4 count threshold and all people diagnosed with HIV in Australia qualify for treatment irrespective of their CD4 count, and that is where we remain. So the important points really is that ART is now, ART or antiretroviral therapy is now recommended for all living with HIV, that it is a lifelong commitment, that adherence is of the utmost importance, and we really need to provide people with strategies to ensure that they have excellent adherence. And we need to, in order to improve that adherence, really provide robust education around the benefits to that individual of taking ART for their health. So in performing a psychosocial assessment before therapy, there are numerous things which can have an impact on an individual's adherence to taking their antiretroviral therapy. So I think it's really important to explain HIV, what it is and how the medication works, what the aims of taking therapy. This is lifelong therapy, so it's really important to explain what the aims of therapy are, not only to the individual living with HIV, but as well as reducing transmission to to sexual or potentially injecting partners. We need to assess an individual's willingness to make that commitment to therapy given its lifelong therapy. We need to explore an individual's mental health, both past and current mental health issues. Depression, anxiety may have a significant impact on ability to adhere to antiretroviral regimens, as can drug and alcohol use. We also need to look at the individual support networks and to remember that many people may choose not to disclose their HIV positive diagnosis to family or friends. We also need to look at the social situation of the individual who's presenting for treatment. What kind of accommodation do they have? What financial situation they're in? Are they working? Are they not working? Are they living in a place in Australia where antiretroviral medication is free to access or not? We also need to look at their work situation. Things like travel, shift work may have an impact on their ability to take their medication. And as I said earlier, recreational and drug and alcohol use can have an impact on adherence to antiretroviral medication. all individuals need to be ready to start HIV medication. It's important they understand that HIV therapy is for life, and that not taking medications on a regular basis can be associated with resistance. So HIV can become resistant to the medication, and then the number of options that individual has for ongoing treatment will be reduced. It's thought that adherence rates of 90 to 95% are required to maintain virological suppression and to prevent the development of resistance. Earlier HIV regimens that we use now, so the ones we would lead with when someone wants to initiate therapy, are very convenient, and the pill burden is small, but with failure, salvage regimens tend to be more complicated with increased pill burden. Our current first-line regimens have pretty low toxicity, and if they do have side effects, generally they're very easily managed. Although the trend is towards early initiation, and in some situations it's now same-day treatment initiation, it's important to remember that not all individuals will be ready to start their HIV treatment immediately, and to provide support and maintain that person engaged in their care, and to continue to follow up with them and support them to achieve the decision to start treatment. So when you're discussing the benefits of starting antiretroviral with the person newly diagnosed, it's important to focus on a number of things. So the first is mortality. We know that commencing antiretroviral therapy increases one's life expectancy, and we'll talk a little bit more about that shortly, but essentially many people living with HIV who now are on treatment will live a normal to near normal life expectancy. It's important to know that being on antiretroviral therapy also reduces progression to AIDS. There's a list of conditions which we call AIDS-defining illnesses, which are signatures of advanced HIV infection, essentially. And we don't see it so commonly these days, but it still occurs from time to time. But we know that being on treatment reduces disease progression to AIDS, as well as serious non-AIDS events such as heart attacks, kidney and liver disease. And increasingly, as I alluded to earlier, we know about treatment as prevention, so that being on an antiretroviral treatment and having an undetectable viral load reduces the risk of transmitting HIV to your sexual partners. This is a journal, and this is a picture rather from the New England Journal of Medicine back in 1998, and it essentially shows the significant impact that commencing protease inhibitors, so early antiretroviral regimens, had on death, basically. So the protease inhibitors came along in sort of 1994, 95, and after the World AIDS Conference in Vancouver in 96, triple therapy with a protease inhibitor in the mix became standard of care. And so the blue line, or rather the grey line, shows the significant increase in uptake of protease inhibitor-based therapy over time. And the blue line shows, with increased use of protease inhibitors, the dramatic drop in the death rate associated with HIV, and in particular untreated HIV. So these are a couple of data sets that regarding life expectancy. So the North America Accord, or NA Accord cohort, this was data presented back in 2013, looking at nearly 23,000 people from the NA Accord cohort in the US and Canada. And these individuals were followed from 2000 to 2007. Over this period of time, there are 1,622 deaths, and they calculated that the life expectancy of an individual aged at 20 during the period of between 2000 and 2007 was approximately 71 years of age. But if that individual then started their antiretroviral treatment when their CD4 count was still above 350 in the years of 2006 and 7, they could expect to live as old as 89 years of age. The UK SHEEP cohort looks at 21,388 people from the UK, and they excluded people who inject drugs from their sample. This one was published in AIDS in May of 2014, and they followed a large cohort between the years of 2000 and 2012, during which time they observed 961 deaths. And they estimated that after being on antiretroviral therapy for 5 years, life expectancy was thought to be 80 years of age. So those data are pretty significant. And I think what I tell my patients ultimately, because over time these numbers will change, but I think the important message is if an individual is diagnosed early in their HIV infection, they take treatment and they remain virologically suppressed, that they can expect to live a normal to near normal life expectancy. And part of that is about access to care. So many of their peers who are a similar age may not go to the doctor very frequently, but for those living with HIV, they'll attend to see their specialist 2, maybe 3 times a year, potentially at least once a year. They'll fast and have their lipids checked and be screened for diabetes. Blood pressure and weight will also be checked. And as any of those cardiovascular risks emerge, they'll be aggressively managed. So ultimately, it's the access to care and the early diagnosis and treatment which are contributing to a normal to near normal life expectancy for people living with HIV, which I think is really very exciting and important to share that information very, very early on. As to when to start HIV treatment, we talked earlier about the history of HIV in Australia, and as of the 1st of April in 2014, as I said, the CD4 count threshold for initiating therapy was abolished in Australia. At that time, we thought we were doing the right thing, but this START study, which was published after this, really reinforced that what we're doing was, in fact, the right thing to do. So the START study was about early initiation of antiretroviral therapy. And so 4,685 people from around the world were randomised 1-to-1 to either commence antiretroviral therapy immediately or to defer their therapy. So in the immediate arm, they initiated therapy when their CD4 count was above 500 cells per microliter. And then in the deferred group, they initiated therapy when their cells fell below 350 or they had an AIDS-defining event. And what we found, so the primary composite endpoints of this study were AIDS, non-AIDS events, and serious adverse events or death. And in the deferred group, 4.1% of participants had a primary endpoint. The primary endpoint was met versus only 1.8% in the immediate arm. And that was driven mainly by tuberculosis and KS. But ultimately, the START study run by the Insight Trials Group showed that what we were doing was the right thing to do, that starting HIV treatment or offering it to all individuals living with HIV, irrespective of CD4 count, was the correct thing to be doing. And this study also showed us that some of the serious either AIDS or serious non-AIDS events were actually occurring at CD4 counts higher than we had originally thought. So it reinforced that offering all individuals with HIV treatment is the right thing to do. The other thing that's evolved over the last decade is the science around treatment as prevention. So that means that if an individual living with HIV takes treatment and has an undetectable viral load, that the risk of transmitting HIV to their sexual partners is significantly reduced. And there are essentially 4 significant studies that prove this point. The first of these was the HPTN-052 study, which looked again at randomising individuals to either commence antiretroviral therapy immediately or to defer their antiretroviral therapy. And so in this study, 1,763 serodiscordant couples were followed up for 5 years or more. In the immediate arm, the participants were randomised to commence treatment when their CD4 counts were between 350 to 500. And then in the deferred arm, the individual deferred therapy until the CD4 count fell below 250 cells per microliter, or they had an AIDS-defining illness. This study went for a decade, and what we found in the deferred arm, there were 43 linked infections. So we did testing called phylogenetics, and we could see that the person who newly acquired HIV during that study had in fact acquired that HIV from their partner who was also in the study. So 43 new infections linked in the deferred arm, but only 3 linked infections in the immediate treatment arm. And of those 3, they were either, the positive partners were either not yet undetectable, so early in the course of their treatment, or had previously been suppressed with an undetectable viral load and had then failed therapy, so that at the time their partner was diagnosed with HIV, they did not have an undetectable viral load. And so this effectively equated to a 93% reduction in linked transmissions. Very exciting finding published in the New England Journal of Medicine in 2016. We saw no linked transmissions when the positive partner who was on treatment had an undetectable viral load. This study was predominantly in heterosexual couples, though, and so we needed to find more data specifically looking at HIV transmission and treatment as prevention in men who have sex with men. So the Partner 1 and 2 studies sought to do this. So the Partner 1 study initially recruited heterosexual and same-sex male couples, serodiscordant couples, where the HIV positive partner was taking antiretroviral therapy and had an undetectable viral load. And these couples reported condomless sex between September 2010 and May of 2014. And in that study, there were 11,066 serodiscordant couples from 14 different European countries. 888 couples provided 1,238 couple years of follow-up. And of those 888, only 340 were men who have sex with men. So then the Partner 2 study was the extension of the Partner study, and this recruited and followed up the MSM couples only. So from September 10 to July 2010 to July of 2017, 972 same-sex male couples were enrolled, and 782 provided 1,593 couple years of follow-up. And in the Partner 1 and the Partner 2 studies, there were no linked transmissions, just as there were not in the HPTN 052 study in the context of undetectable viral load. The Opposites Attract study was the study done by Australia, the Kirby Institute. This looked at 358 gay male couples, serodifferent couples in Australia, Thailand and Brazil. There were 343 couples who had at least 1 year of follow-up visit, and 591 couple years of follow-up were analysed. And again, in the Opposites Attract study, there were no linked transmissions. So between the Partner 1 and 2 study and the Opposites Attract study, there have now been close to 90,000 combined acts of condomless anal sex reported in MSM couples where the HIV positive partner had an undetectable viral load and the HIV negative partner was not taking PrEP. So we have some significant data to back up treatment as prevention and under the undetectable equals untransmittable movement. So maintaining HIV viral load less than 200 copies per mil with antiretroviral therapy, we think prevents transmission to sexual partners. We want that individual to have been suppressed on their ART for at least 6 months and to use another form of HIV transmission prevention. And of critical importance, obviously, is adherence. If one is going to rely upon an undetectable viral load as their mode of HIV transmission prevention. So it's important to counsel patients that transmission is possible during periods of poor adherence or treatment interruption when the viral load rises above 200. And of course, it's important to note that a viral load less than 200 copies per mil does not prevent either acquisition or transmission of other STIs. And so U equals U, undetectable equals untransmittable, is a movement that got going in the United States by a gentleman called Bruce Richmond. And it's been endorsed by hundreds of HIV organisations globally. And so the ASHM Guide for Clinicians to Discuss U equals U was published in July of 2018. And what is quoted there is that if people take ART daily as prescribed and achieve and maintain an undetectable viral load, there is effectively no risk of sexually transmitting the virus to an HIV negative partner. Important things to consider, of course, are the impact of adherence, recurrent viremia and STI acquisition, and that not disclosing your HIV status to your sexual partner because you're relying on U equals U can have an impact on a sexual relationship and potentially legal consequences as well. And it's important that we as healthcare professionals looking after people living with HIV and not the people providing legal advice around this but we know how to signpost those people living with HIV to organisations where the right legal advice can be provided. So in step 2 of preparing someone for antiretroviral therapy is to look at their baseline investigations. So there's a list of baseline investigations. You will have seen the HIV monitoring tool, no doubt, that have been performed. There are a list of tests that we perform when someone's initially diagnosed with HIV to assess what treatment we can use and their general health and other comorbidities that they may have. The time of initiating antiretroviral therapy is a really good time to check that all those tests have been done. And even in a well individual, those baseline tests could have a significant impact on choosing which antiretroviral therapy you may initiate with them. What are we looking at? In terms of HIV surrogate markers, we're monitoring 2 main things. We're looking at the CD4 cell count, so the individual's CD4 cells. In the past, as I said, we use that as a guide for either when to initiate antiretroviral therapy or when to initiate prophylactic antibiotics to protect an individual from opportunistic infections such as PJP and MAC. We also measure the HIV viral load, and really now the HIV viral load is the main measure that guides us that individual is taking their treatment successfully and that the virus is fully suppressed. When someone's diagnosed with HIV, it's now standard of care to organise what's called an HIV resistance genotype. This tells us whether the virus that individual has acquired may or may not be resistant to any of the standard medications that can be initiated. Most people will have a genotype available prior to initiation of their HIV treatment, but increasingly we're looking at early treatment and even same-day treatment initiation. And if an individual chooses to start therapy before their genotype comes back, which can take up to 3 weeks, then there are particular regimens, robust regimens that are recommended in the guidelines if you're going to start without the resistance genotype. And you can always change the regimen later if the resistance genotype does come back showing some transmitted resistance. There is a test called the HLA-B5701 test, which shows whether or not an individual is likely to have a significant reaction to a medication called abacavir, called a hypersensitivity reaction. So before one initiates the drug abacavir, it's critical to actually organise an HLA-B5701 test. If that individual is positive for that test, then they should never be given the drug abacavir, and their medical files should be marked that they have an abacavir allergy. We want to check an individual's kidney function. We do that by both doing urea electrolytes and creatinine, so doing a blood test, but also looking for proteinuria and performing a urinalysis, essentially. We're also interested in looking at co-infection. So hepatitis A virus, we can vaccinate for that, so we can perform hepatitis A serology, but more importantly, co-infection with hepatitis B or C. Hepatitis B is critically important because the drugs we use, some of the drugs we use to treat HIV overlap with hepatitis B treatment, and so it's important to choose specific drugs if an individual is living with both infections so that we can treat both HIV and hepatitis B simultaneously. Hep C used to be far more difficult to cure in the setting of HIV co-infection. With the era of direct-acting antivirals, that's changed. And the major issue with Hep C co-infection largely is about drug-drug interactions and choosing the direct-acting antivirals that cure Hep C that won't interact with the HIV regimen that individual is taking. Remembering that HIV is largely a sexually transmitted infection, it's also important to screen for other STIs, not only at diagnosis of HIV, but if an individual is at ongoing risk on a routine basis. So we need to be considering syphilis and chlamydia and gonorrhea also. A baseline tuberculosis screen can be performed either by way of performing a chest X-ray, a Mantoux test, or quantiferon gold testing. And quantiferon gold testing is largely the mode that many services use in this era. Full blood count, kidney and liver function, we like to perform before initiating therapy. We also like to ensure that the individual who's recently been diagnosed with HIV and is going to start treatment, has fasting bloods performed before treatment, because we know that some of the medications can potentially have an impact on lipids. So a fasting assessment to rule out diabetes and to perform a cardiovascular risk assessment by performing fasting lipids is also important. And also for our female patients to perform a pregnancy test, because that would have an impact on the drugs that we may choose to initiate. We then look at the special circumstances. So there are certain conditions or scenarios that have an impact on when we initiate antiretroviral therapy and what we choose to initiate with. So the things that we might consider are individuals with a specifically low CD4 count. That may be important for a number of reasons. One is that certain antiretroviral regimens historically are thought to perform less well at low CD4 counts. So it has had an impact on the choice of regimen initiated in the past. Similarly, at lower CD4 counts, there is a potential for risk of opportunistic infections. And so for someone with low CD4 count, it's important to perform a systems review and a physical examination and consider the presence of opportunistic infections before initiating antiretroviral therapy. The resistance genotype might come back showing what we call transmitted resistance. So the virus that somebody has acquired may actually have resistance mutations. And so unfortunately, all baseline or first-line options may not be an option for that individual if they have transmitted drug resistance on their baseline genotype. But it's important to note the majority of genotypes we see are what we call wild-type genotypes, where there is no resistance. The abacavir hypersensitivity, we talked about performing the HLA-B5701 test. And if that individual has a positive HLA-B5701 test, they should never receive the drug abacavir. We've talked about the importance of screening for hepatitis B and C infection and choosing antiretroviral therapy either to cover Hep B co-infection or to ensure that there are no drug-drug interactions with the direct-acting antivirals we would choose to cure the hepatitis C virus co-infection. Some of the HIV drugs may be associated with toxicity, so cardiac toxicity associated with abacavir use, renal toxicity associated with tenofovir use. So, and protease inhibitors have been associated with impaired glucose tolerance. So if an individual has a particular comorbidity, then it might guide us to steer clear of particular antiretroviral therapies. Screening for TB, latent versus active TB. If an individual's likely got active TB, you need to clearly consult with a mentor at a tertiary centre, ensure they're fully assessed and that the tuberculosis is treated. And that may have an impact on the timing of the initiation of their HIV medication. It's important also to have a discussion with women of childbearing age, A, to exclude pregnancy, but B, to find out what their plans are or considerations are for pregnancy, because in the past, some medications have been associated with particular toxicity to the fetus, or we don't have adequate data yet about the safety of newer antiretroviral agents. So if someone is considering pregnancy, or if someone is found to be pregnant, then we need to choose regimens which we have a proven safety track record for in pregnancy. These scenarios that we've just discussed, these special circumstances, will be discussed or outlined in the cases that you'll have a look at after the module. So in terms of the lower CD4 count I alluded to earlier, or in symptomatic individuals, so if someone's got an unrecognised opportunistic infection or they've got symptoms, initiating antiretroviral therapy may have significant consequences and can even be fatal. And cryptococcal meningitis is one of those scenarios. If anybody is symptomatic or they have a very low CD4 count and you're just not sure, it's critical to speak to your mentor or a hospital-based specialist, but always be thinking about those late presenters with low CD4 counts and whether or not they may have opportunistic infections on board. And that's not only when you're initiating their therapy for the first time. It might be if they've had a treatment interruption and then they have a low CD4 count and then they're reinitiating therapy. So it's important to exclude or treat any underlying opportunistic infections in the symptomatic individual, and to talk about the concept of immune reconstitution illness. So when someone presents with a low CD4 count with advanced HIV infection and they commence their therapy, the advanced immune system, being in a sort of weakened state, if you like, has a reduced capacity to fight off infections that may be present. But once they start that antiretroviral therapy and their immune system function improves, they can then develop symptoms of an opportunistic infection which may have been present. This can be associated with significant inflammation, and we call that an immune reconstitution illness syndrome, or IRIS, or inflammatory syndrome, or IRIS. And that is a medical emergency. You really do need to consult with a mentor, preferably a hospital-based doctor, if you're worried about an individual who develops symptoms when they've commenced antiretroviral therapy. It's also, as we said, the low CD4 count thing is important if an individual has a CD4 count below 200, for example, when they consider Bactrim as prevention, provided they have no symptoms of PJP infection. And that's because the Bactrim treatment dose for preventing PJP is different to actually treating it. Again, for your individuals who present late with low CD4 count, always worth your while talking to a mentor or referring them to a hospital for further assessment. Then to choosing your antiretroviral regimen, it's important to realise that the young and well person may be able to have any regimen, including a single pill regimen, but that the baseline test will have an impact on the regimen which you can initiate, as we've just gone through. It's also important to think about dosing twice daily, once daily. Drug-drug interactions, an individual may be taking other medications for other medical conditions, so that's really important to check when you're working out which antiretroviral regimen you wish to initiate, that if they're already on other medications, that there are no potential drug-drug interactions. Some antiretroviral therapy agents also need to be taken with food, so it's worth thinking about those as well. Ultimately, what you're trying to do is tailor the antiretroviral therapy regimen to the individual. You want to choose the best regimen for each person, and I tend to think about it as a shared decision-making process where I present that individual with all the potential options for them, and then we talk about the pros and cons of each of those regimens, and we end up making that decision together. And obviously, if women are of childbearing age, it's important to think about pregnancy potential and discuss that before choosing the first regimen. So if you do have any questions, unfortunately, this is a recording. I'm not able to answer those now, but if you can type them into the discussion board, and the course facilitator will be able to answer those on the discussion board for you.